This is the Shahid Shah Show. Straight talk on building, buying, and investing in digital health. No hype, no buzzwords, no speculation. Just what actually works, maybe what doesn't, and most importantly, why. If you're building healthcare technology or buying it, this is where reality shows up. I want you to picture a hospital that just finished a 12-month project to deploy an AI system for prior authorization, something we just talked about in our previous episode. The system works. It reads clinical notes, fills in the payer forms, submits the request, of course, and tracks the response. It does this faster than the humans did it before. The vendor demo, of course, was impressive. The implementation team is proud, and the hospital is now very efficiently doing something that it probably shouldn't do. Prior authorization for many procedures is medically indefensible. The denial rates on well-established interventions are embarrassing. The clinical evidence for underlying requirements that somebody needs to ask permission before providing a treatment that already has an evidence base is often non-existent. But the hospital didn't question that. They dutifully automated it. They built a sophisticated AI system to do a stupid thing faster. Most of us who have been in the industry for a long time realize that healthcare is one of the few industries where complexity is routinely mistaken for sophistication. Happens in a lot of different places, but we get to notice it firsthand because when we're patients and we see something stupid looking at us straight in the face, we recognize it instantly. When you see something dumb happening in a giant manufacturing facility or maybe behind the kitchen in a restaurant, those things aren't visible to us. But when we see these things in front of us in healthcare, we can see it. And when something dumb, something stupid happens, and it happens in front of us over and over again, we recognize it. So it is one of the few industries where complexity is routinely mistaken for sophistication, but we can see it. Every year we add more systems, more dashboards, more alerts, more compliance checklists, more documentation requirements, more predictive models layer on top of other predictive models, more committees to govern the committees that approve the dashboards. At no point does someone just simply stop and ask whether any of this should exist in the first place. That's the problem this episode's about. A few years ago, a physician named Melinda Ashton wrote a piece in the New England Journal of Medicine describing something she called getting rid of stupid stuff. I interviewed her a few years ago and was just amazed at how crisp and clear and cogent her arguments were, but it still happens. The acronym that Dr. Ashton set up is called GROSS, GROSS, getting rid of stupid stuff, which is either unfortunate or perfect, depending on your sense of humor. The core idea is this. She said before you try and improve a system, remove the unnecessary work from it. Not optimize it, not automate it, just remove it. Her team at Hawaii Pacific Health went through their electronic health record and systematically identified documentation requirements, alerts, and workflows that added no clinical value. They asked clinicians directly, what work do you do that you believe is pointless? The answers were not subtle. There was a lot of pointless work. And when they removed it, clinician satisfaction improved. Not because they added anything, but because they took things away. What if the solution to so many of our burnout problems was just getting rid of stupid stuff? That was the question that was posed. Now, around the same time, in a completely different industry, Elon Musk was describing what he calls the algorithm. It's a 5-step engineering discipline used inside Tesla, SpaceX, Neuralink, and other places now where Musk-ish disciples have gone. Now, I realize Elon Musk is a polarizing figure. Some people admire him, some strongly dislike him, and others disagree with his politics, management style, or maybe even just his public behavior. That's completely fair, but for this discussion, I'd like you to separate the messenger from the operational principle. You don't have to agree with somebody on everything to recognize when they've articulated a useful engineering discipline. What matters here is not Musk as a personality. It's whether the underlying idea is true and whether it helps us stop building increasingly expensive systems around work that should never have existed in the first place. Now, let's get back to the engineering discipline. The steps are question every requirement, delete any part or process you can, simplify and optimize what remains, accelerate cycle time, and then, only then, do you automate. The sequence is not negotiable. Musk, and now his many disciples across many companies, are explicit about this. You don't automate before you've deleted. You do not optimize before you've questioned whether something is even necessary. If you skip to step five, the automation, without doing the steps one through four, you end up automating a process that really shouldn't exist. And the automation makes it harder to eliminate later because now there's infrastructure built around it. Of course, in healthcare, we see this happening constantly. And again, we see it because we're patients, not just in the profession itself. Healthcare as an industry almost professionally is committed to jumping straight to step five, the prior authorization AI when no prior authorization should be necessary, the clinical documentation generator when the documentation should not be necessary, the remote monitoring dashboard that surfaces 1,000 data points a day that clinicians don't even have time to review. It's all automation, all layered on top of processes that were never questioned, never simplified, never examined for whether they should exist at all. Now, a lot of this we discussed in our previous episode about not making the right decisions. If you have decision debt and you didn't make the right decisions, it turns out you're just adding more things on top of other things that shouldn't exist. So today we're going to combine Ashton's gross principle and Musk's algorithm and apply them to digital health, clinical AI, and the tech decisions that hospitals and payers are making right now. Because if there's a unified framework for why so many digital health deployments disappoint, and there is, this might be it. Let's start where builders need to start. If you're building a digital health product, the most important question you can ask about your product is not, what does this thing do? It is, what does this thing that I'm making eliminate? That's not a design philosophy. It's the most important business model question that you have. Because here's the thing about healthcare buyers. They're under enormous budget pressures, and they have been for years. Adding capability costs money and justifies itself slowly, if at all. Eliminating cost or work justifies itself immediately. When a CFO asks a question, asks whether a product does, and the answer is, it removes 3 steps from prior authorization workflow and eliminates 1 FTE of manual work, that's a calculable ROI. When the answer is, it surfaces insights to inform clinical decision making, that's a philosophy. And if you're trying to be a philosopher to a CFO, to a clinician, you got problems. Philosophies are hard to budget for. Eliminations are much easier. So let's walk through some of the most commonly targeted areas in digital health and apply the algorithm or Dr. Ashton's gross methodology, honestly. Start with prior auth. We talked about it recently. We know that the government is after this product problem with a vengeance, with new standards, new capabilities required, etc. There are dozens of startups building AI systems to automate this prior auth. The pitch is always some version of this. Our AI reads the clinical record, understands the payer's criteria, and submits the request automatically. Yay! That's a real capability. It does save administrative time, but it's step 5 of the algorithm, executed without steps 1 through 4. A gross and algorithm approach asks first, why does this authorization require exist for this procedure in the first place? A lot of prior auth requirements were created for cost containment purposes that no longer apply. Perhaps no longer apply. Some were created in response to prescribing patterns that might not exist. Some are contractual artifacts or payer agreements that predated the clinical evidence base that we have now. The correct first move is to identify which authorization categories produce high denial rates or unnecessary friction, then challenge those requirements directly with the payer, with the regulators, with the clinical evidence. Narrow or eliminate the requirement for procedures where it isn't justified. Only after that work is done do you build the automation for the cases that genuinely remain. I call this problem a stroke of the pen problem/solution. When you can convince somebody to change a rule, it doesn't have to be automated. When you can convince your boss to allow you to do something differently just by signing a document, changing a policy, do it. It is much, much easier than automating. The sequences where we remove administrative burden instead of automating the entire existing process is a much better way to go. The automation you do build is then smaller, cheaper, faster to implement because you've deleted much of the problem before you tried to solve it. Now take clinical documentation. Large language models that generate clinical notes from physician-patient conversations are getting a lot of attention right now, and for good reason. The pitch is compelling. The AI listens, transcribes, and drafts the notes so the physician doesn't have to. But in many organizations, the real problem isn't that physicians type too slowly. The problem is that the documentation requirements themselves are excessive. Study after study has shown that clinicians spend enormous portions of their working time interacting with the EHR rather than with patients. Of course, scribes and digital scribes and ambient scribes, they are trying to help with that problem. But when that interaction occurs with the EHR, that time is dominated by fields filling in that have never been clinically validated as necessary. Fields that exist because of historical billing rules, compliance requirements from audits that happened a decade ago, or defaults that nobody ever changed because nobody ever questioned them. A gross approach asks which documentation fields in the forms actually affect clinical decisions, which fields exist only for billing, which information lives somewhere else in the system and is being entered again manually. Delete those fields first. Narrow the notes significantly, then apply the language model to assist with a smaller set of truly necessary documentation. The model does less work with less error surface, fewer tokens being used, they're far less expensive, and it's a better product. It's a product that's easier to sell because the buyer can see exactly what disappeared. Remote patient monitoring is yet another area where this plays out almost by default. Programs deploy connected devices for hypertension, diabetes, heart failure, maybe, post surgical recovery. The devices are generating data, lots of data. The data comes in continuously, and at some point, somebody realizes that no one is looking at most of it. The typical response, of course, is, oh, we need a dashboard because nobody's looking. Let's add another screen to build a dashboard. I call dashboards one of our greatest failures, not because the dashboard itself looks bad, but the point of the dashboard is to surface things that maybe you weren't supposed to be seeing anyway. Sometimes you are, sometimes you're not. But just building a dashboard might be a failure condition because then it's an alert system on top of the dashboard that you need because the dashboard has too much stuff. Then an AI triage layer on top of the alert system to help determine which alerts are worth looking at. At this point, you've built 3 layers of infrastructure to manage data that probably shouldn't be surfaced to clinicians in the first place. The Musk approach asks a different question. Does a clinician need to review this data at all? The honest answer for most readings for most patients on most days is no. Values that fall within expected ranges for that patient on that day, given their history and medications, add no actionable information. They generate cognitive load. They can contribute to alert fatigue. They consume nursing time that could be spent on something that actually changes the care plan. Delete those readings from the clinical workflows entirely. I know this sounds easy, and I'm making it sound almost trivial. It's not. But where would you rather spend your time? Building a bunch of tools that nobody uses and hundreds of hours there, or spending hundreds of hours figuring out how to delete things? Surface only genuine outliers. If automation is still warranted, automate against a much smaller and more relevant data set. Digital therapeutics deserve their own moment here because the engagement problem is that space is almost perfectly explained by skipping steps 1 through 4 in the algorithm. Platforms typically respond to low engagement by adding features, gamifications, push notifications, behavioral nudges, streak counters, reminder messages, all of which is step 5, automation and acceleration applied to a problem that hasn't yet been simplified. The actual reason patients are abandoning most digital therapeutic programs is basic. The task burden is too high, too many steps, too much data entry, too many interactions required per week to maintain eligibility in the program. How many of these required interactions add clinical value? Usually the answer is that the program is designed around data collection requirements for the clinical trial or the engagement metrics that matter to investors rather than around what the patient can realistically sustain in their actual life. If you're just tuning in, this is the Shahid Shah Show, where we cut through the noise in digital health and talk honestly about how healthcare technology gets built, bought, deployed, and paid for. Today, we're looking at why digital health and healthcare in general keeps automating the wrong things and how a combined framework from a physician, researcher, and an aerospace engineer might be the most useful thing to hit healthcare operations in years. Now, let me talk about what this looks like from the buyer's side. Because Dr. Ashton's gross and the Musk algorithm framework isn't just for builders. It's arguably more important for people making purchasing decisions at deployment decisions inside hospitals. The AI trap, and it is a trap, works like this. A hospital identifies a painful workflow, prior auth, documentation burden, care gap outreach, discharge planning, whatever it is. The pain is real, real. Leadership wants to address it. A vendor shows up with an AI solution. The demo is good, the contract gets signed, and 18 months later, the hospital has an AI system running on top of a broken process that is now harder to fix because there's a multi-year contract wrapped around it. AI is extremely good at automating structured tasks. That's not a criticism, it's just what it is. But if the underlying process is poorly designed, AI makes the flaw run faster. The way to avoid this as a buyer is to embed the algorithm into your technology governance. And that's not complicated. Before approving any digital health initiative, require the team proposing it to answer 3 questions in sequence. First, what requirement are we questioning? Every initiative must begin by identifying the requirement that created the problem being solved. Is that requirement clinically necessary, legally required, a billing artifact, an organizational habit? If it can be changed or eliminated, that should be happening before any technology is purchased. Now, second, what will be deleted? Every initiative should identify what step, process, data field, or workflow will disappear when the new technology is deployed. Not what capability will be added, what will be removed. If the answer is nothing, if the technology only adds capability without eliminating anything, the ROI case should be hard to make, and the cognitive load on staff is likely to go up, so you have to question it. Third, how will the remaining process be simpler? The deployed system should be less complex than what is being replaced, not more. If the technology adds dashboards, interfaces, new data entry requirements, new training burdens, without a commensurate reduction somewhere else, step back and ask what you're actually solving. Only after those 3 questions are satisfactorily answered should the discussion turn to what the AI does, how the model was trained, what the vendor's implementation timeline would look like. Organize these 3 questions with the conversation we had earlier about decision debt and decision making. Make this part of the decision making process so you can do deletions before you do additions. Now, all of this sounds like it would slow down procurement. It actually speeds it up because you get into the central point of what you are buying. Because vendors who can answer these 3 questions clearly are the vendors whose products work. Vendors who can't answer the question about what you're removing versus what you're adding are telling you something important, that they've built a capability in search of a problem rather than a solution to something that must be eliminated. There's a budget argument here that CFOs and finance committees should be paying attention to as well. Products that eliminate work have a fundamentally different cost conversation than products that add capability. Now, it requires your governance to be far superior than you've ever had it before. You got to have better decision making. You have to have a reduction in decision debt because these products are eliminating work. You have to decide which work do we want to eliminate. And that's not your vendor's problem. That's your problem. If a tool removes a step that currently costs 3 hours of nursing time per day per unit, that's calculable. Put a number on it. You can compare it to the cost of the contract. The ROI conversation should take minutes and hours, not days, weeks, or months. If a tool promises to enhance clinical decision support or improve care coordination, the ROI conversation is a lot harder. What does enhance mean? Compared to what baseline? Over what time horizon? With what confidence? How did you run the time and motion studies? Boards and finance committees have been burned time and time again by these second kind of conversations, and they're increasingly skeptical, as they should be, of anything that doesn't have a clear elimination story. The gross principle isn't just a good clinical design, it's a procurement design. Let me say that again. Buying things becomes easier when you use the gross principle or you use the deletion idea. It produces cleaner contracts with more defensible ROI that a vendor can't just talk around. There's a pattern in digital health failures that becomes obvious when you see it. A problem exists, technology is purchased to address it, The technology addresses the surface symptom, but leaves the underlying process intact. Complexity increases, staff burden increases, maybe burnout starts to occur. The pilot succeeds by the metrics the vendor proposed. The broader deployment disappoints by the metrics that actually matter, and nobody quite understands why. The reason is almost always the same. Something was automated that should have been deleted. The combined gross and algorithm framework is a discipline, not a checklist. It requires organizations to do something culturally uncomfortable in healthcare. In your governance committees, where you are making these decisions and reducing decision debt, acknowledge that a significant portion of existing work is not just inefficient, but unnecessary, and that adding technology to unnecessary work makes it worse, not better. That requires somebody to say out loud that the process we've been running for 15 years is just stupid and we shouldn't be doing it. That the documentation field we've been requiring clinicians to fill out has no clinical value. That the authorization requirement we've been complying with was never medically necessary or justified. And so on and so on and so on. But these are not comfortable conversations. They're far less uncomfortable than the alternative, though, which is a multi-million-dollar AI deployment that makes a broken system run faster while everybody wonders why the promised benefits never materialize. For builders, the practical takeaway is this: design your product around what disappears, not what appears. The strongest product positioning in digital health right now is not, we add intelligence to your workflow. It's, here's the specific thing that goes away when you use us. That framing isn't just better marketing, it reflects better engineering. A product built around elimination is almost always simpler, more reliable, and easier to implement than one built around addition. It has a smaller failure surface, it integrates more cleanly, it trains faster, and it gets renewed because the thing it eliminated stays gone. Hopefully. For buyers, the takeaway is equally concrete. Before any technology initiative reaches the approval stage, require a gross and algorithm pass. Remember, gross means getting rid of stupid stuff. And the algorithm says, delete things. What existing work would be eliminated if we did this differently? Ask that question. What requirements should be questioned before we automate them? Again, ask the darn question. What can be deleted before we build something new? If your governance process doesn't ask these questions systematically, you'll just keep doing what most healthcare organizations do, approving tech that efficiently performs tasks that the organization should have stopped doing years ago. The business model case for all of this is also worth being explicit about. Healthcare budgets are not growing fast enough to fund the volume of healthcare initiatives currently being pitched. Organizations are increasingly under pressure to show that technology investments deliver measurable, near-term value, not theoretical long-term improvements and outcomes that require years to validate. Elimination has a clean budget story. Addition does not. The vendors that will survive the current market corrections are the ones that can show precisely what work disappears and precisely what it costs to make that happen. The vendors that will struggle are the ones that are still pitching capability enhancements to organizations that need cost reductions. The gross principle and the Musk algorithm aren't just engineering frameworks. They are a survival guide for the digital health market as it gets more selective. And remember, whether you're talking about digital therapeutics, a brand new medical device, it could be a new EHR feature, it could be a brand new AI model, all of it needs the same central question. What are we adding and what are we removing? If we're adding faster than we are removing, we've got a major problem. So, one last thing before we close. This framework is only useful if it's applied sequentially. The order matters. Delete first, simplify second, automate last. Let me say that again. Delete first, simplify second, automate last. In that order, you get a system that is leaner, faster, and less expensive to run than the one you replaced. In any other order, you get more infrastructure protecting processes that should have been eliminated. And you'll be right back in the same conversation in 3 years wondering why the new platform didn't deliver. So here's what I'd love to hear from you. What is one workflow in your organization that should be eliminated rather than automated? Tell us. Email us, add it on GitHub, put it on LinkedIn. What requirement exists today that's simply there because nobody ever has questioned it? Give us some examples. Help out your colleagues and say, hey, I questioned this and we got it removed. The more we hear that happening, the more the frontline nurses, doctors, clinicians, administrative staff, front desk folks, they can start to question because their colleagues say it's okay to. These examples that I'd love for you to share don't have to be big, dramatic examples. The most interesting ones are usually the small, persistent things that everybody knows are pointless, but that nobody has ever had the standing to remove. Wouldn't it be nice if we just had a catalog of things, even in your hospital or across the systems, where we all are excited about the thing that we deleted more than we are excited about the thing that we bought? Post your examples, as we said, on GitHub, LinkedIn, send it to us via email if you don't want to be attributed. If you rather share that privately, it's okay. Don't worry about it. We'll bring the patterns into future episodes. Real questions, real experience, real decisions, and the business models that make all of this possible. These are the things that we have to be discussing. So let's stop doing stupid stuff. Run the algorithm. The tech will take care of itself. This is the Shahid Shah Show. And until next time, keep innovating, but stay real and practical.